Hi, I'm Tom Burke, Associate Dean for Public Health Practice here at the Johns Hopkins Bloomberg School of Public Health. Welcome to Public Health on the Inside, your inside look into the world of public health. Today I'm joined by my colleague and friend, Dr. Larry Wissow. Larry is a pediatrician and a professor in the Department of Health, Behavior, and Society and the Department of Epidemiology here at our school. He's also a graduate of the school's MPH program, and he has a really unique background which bridges the clinical world, the world of mental health and psychiatry, and the world of prevention and communication. His specialty has been communication with doctors about the doctor-patient relationship, particularly how it relates to issues of mental health in pediatric care. He's focused on the mental health of children. Mental health issues are unfortunately very often misunderstood and neglected, particularly in children. Larry, thank you so much for joining us today.
Thanks for the chance to be here with you, Tom.
So Larry, you have a fascinating background that really bridges multiple worlds. Perhaps we could start by you telling me a little bit about your background and how you found your way to our public health school.
Well, it's a long story. I was a child of New Jersey, as you
That's
were.
always a very cool
That's right,
thing,
right,
actually.
Right, the largest exporter of people to higher education of any state. And found myself in North Carolina in medical school, which was at the time the farthest south I had ever been. And I fell under the influence of one woman in particular, Dr. Eva Salber, who was actually a South African expatriate. She was part of this relatively large cohort of South African docs who had fled South Africa during the apartheid era. So this was now the late 1970s, had been very much involved in the whole sort of social medicine upheaval that was going on in the United States. And she really convinced me not only that medicine had a social mission that couldn't be ignored, but also really an epidemiologic underpinning. And she sent me out to a couple of communities in North Carolina to both qualitatively and quantitatively try to sort of understand people's healthcare needs. And I was hooked on that sort of an approach, which really was not that common, at least in U.S. medical schools at the time.
Yeah.
So then I had to pick something in the match, and I ended up deciding to match in pediatrics, and I matched at Johns Hopkins. When I finished my pediatric training, I actually wanted to do something which now is very commonplace, but at the time was hard to do, which was really to combine child development, child mental health, and child public health, and a little bit of neurology. And at the time, these were very completely segmented things. So I ended up actually over here in the School of Public Health doing a fellowship in clinical epidemiology, which really cemented my idea that public health was sort of the underlying thing out of all of this. And I ended up, though, getting recruited back to the School of Medicine to co-lead, along with a social worker, the child abuse program there. So for about 7 years, I went around the hospital with this idea that I was supposed to figure out, which kids were abused and which kids weren't. And so this is the canary in the cage sort of a thing. And I felt like I was turning into a forensic pathologist, which is really not what one wants to do if you're a pediatrician. And I fell in with Deborah Roeder, who you know
Yes,
well,
sure.
who's
our communication person.
Our communication person. And together we concocted this idea that, well, maybe if you could only speak to families in a more sort of open and engaging way, they would tell you when they were troubled at a level that might lead to harming their kids, and that this would be a preventive sort of a thing, or at the very least a way of trying to understand which kids were at risk before something actually happened to them. So that became my line of research within child abuse.
What an amazing journey, and it actually underscores the fact that public health is the place where you can connect so many dots, really.
Absolutely.
And work toward things like communication, which may really revolutionize our approach. Mm-hmm. So I want to ask you about mental health issues in children. As we mentioned, it's unrecognized. How big of a problem is mental health
in children in terms of our broader public health issues?
Well, I think there are a couple of sort of, rules of thumb you could think of. So the people think that the prevalence rate of at least sort of treatable or worthy of intervention mental health problems in kids is maybe about 10%. So not that different, let's say, from among adults, but it's substantial. A study was done a few years ago looking at the lag time between the onset of symptoms and the receipt of treatment for people with anxiety disorders, which is probably the most common, form of mental health problems, or one of the most common forms, and where the onset is almost usually in childhood. And that also, unfortunately, comes up with a number 10, so about 10-year lag. So that is most anxiety problems start in childhood, don't get treated till adulthood. So it gives you some idea of the magnitude of the problem. And when you think about the impact of having potentially sort of disabling or derailing, condition during that entire time that's so critical to your development, this entire time that's so critical to your development of your social skills, your educational and cognitive capacities and things. So really that's the big thing. I mean, we often think about mental health problems as something where you're really, keeping someone from doing something drastic, and obviously that's super important. But the thing that really gives it such a huge public health impact really is the impact on people's long-term achievement, their ability to succeed in school and ultimately to succeed at work, to succeed socially, to raise families.
I've talked to so many people who have concerns about their children, particularly as we talk, it's the beginning of the school year. Childhood anxieties really begin to manifest themselves in so many ways, and many parents are really troubled by the fact that their kids are just so worried about things. Everyday life, of the challenge of getting on the school bus, the challenge of getting to school, and coping with the anxieties that the world really puts upon young children. It's a tremendous challenge. And you've come up with some really unique approaches to talk to the clinical community about this, about children's health. And I'd love you to talk about your program with the Maryland Department of Health and Mental Hygiene, the BHIP program.
Okay. Well, I wish I could take more personal credit for these things. Obviously, like lots of good ideas, you steal them shamelessly from other people.
It's like
right?
jazz music.
Yes.
We build on one another, right?
But the idea about trying to take care of kids' mental health problems is first of all, you want to try to find the kids where they are. The Willie Sutton principle, rather than trying to get them to come to you. And secondly, because most mental health problems are either shared with other family members or need to really be thought of in a family or a social context, you ideally try to find kids where they are with their parents. So if you think about the places where most kids actually get their mental health support, it's either in schools or in their primary care settings where they go to the doctor, because kids overwhelmingly come to the doctor with their families. So programs like BHIP, the state's behavioral health and pediatric primary care program, are meant to try to support the capacity of nurse practitioners, pediatricians, family docs, family nurse practitioners, people who are seeing kids for child health maintenance care, to be able to be both better dispensers of mental health care themselves, but also a better gateway into the system. And to some extent, what this really requires is a shift in the culture of primary care, because despite the fact that generalists see lots of mental health problems, most of the time it's formed only a very small part of their training and not something that they feel comfortable doing, and actually as a consequence not something that parents necessarily think of turning to them for help with.
Yeah. Now, you've worked in what I consider to be an emotionally difficult issue of child abuse. And if a parent is concerned or a family is concerned that a child seems to be really suffering with anxiety about school or other issues in life, should they
Ask their pediatrician for help?
Absolutely. I think that there are many pediatricians who, right off the bat, would have really good advice about that. And if they don't, programs like BHIP are exactly what it's for. The pediatricians are good listeners, and then they can call up and get some backup and deliver that.
I don't recall any questions about anxiety or things that might open the door to perhaps prevention of mental health issues. Are you working to change that with the BHIP program?
Yes. I think one of the things that you're pointing out is that we really do need to change the culture of primary care. It's interesting that from a leadership point of view, the field of pediatrics in particular has emphasized what they call the new morbidity, which has been the new morbidity for about the past 30 years. There's a tremendous recognition at the leadership level that these issues are at the core of anticipatory guidance and well child care and health promotion, really alongside of monitoring developmental and learning things, other aspects of sort of well-being. But it's interesting, it has not managed to penetrate the pediatric training programs, even after all this time. And so programs like BHIP are, in a sense, remedial. What we find is that when people go out into practice, what they realize is this tremendous, unmet need among the kids that they're seeing. And interestingly enough, you would think that it would be the old coots like me who are the most resistant. It actually is the opposite. The new docs coming out are very much imbued with their, what they got to do, and it's all medical. It's the older docs, as they're in practice, who realize the level of need and who come back to these programs and really want to learn more about how to manage the mental health stuff that they're seeing.
And your program is making the information available to them, all the members of the clinical
right.
community.
The way these programs like BHIP work, and the flagship one is in Massachusetts called MCPAP, is basically if you have a phone, you have a curbside or an informal child psychiatric consultation. You call the number, and within a day, you can get a call back from a child psychiatrist or a developmental psychologist who will basically informally, answer your question, give you some tips, help you with some referrals.
And that's for clinicians.
Right.
Yes.
Right. It's for the primary care clinician.
We still need that for parents, but this is
yes.
clinician based.
Although we certainly encourage parents to say to their doctor, their nurse practitioner, I've got this issue. I know that there's this program out there. If you can't answer my question, they can help you, and then you'll know something, and you can help the next family that comes along.
Larry, this work is inspirational, and really, it could change the way that we take care of our children and how we consider issues of mental health in children as part of the broader issue of public health and clinical care. You came about this journey in kind of an unconventional way. How do we prepare the next generation of clinicians and public health students?
Well, I think if you wanted to give like a simple answer, it would be, it doesn't matter what piece of the puzzle your preparation is in. What does matter is your willingness to step into the shoes of the people who represent the other pieces of the puzzle. The thing that's been amazing to us, and I think what marks the journey, has been just realizing your own innate unwillingness to realize that other people see the world differently than you do. We did some work in North Carolina with some, wonderful and committed psychiatrists who were very interested in working with primary care folks. We said to them, the pediatricians learned da-da-da-da-da at the AAP meeting. Now, so the AAP is the American Academy of Pediatrics. It's the national, organization of pediatricians. The psychiatrist said, what's AAP? People who live one clinical reality don't know what another person's clinical reality is like. So I think that there's so many different pieces of the puzzle. It's really hard to say that. I don't think anybody needs to know them all, but you have to have an appreciation for what those other pieces are like and what the world looks like from those other places, and then you can be a good bridge. I think that applies to lots of different, public health issues, but certainly to this one in spades.
That's the great thing about public health. It is the silo busting profession that
exactly.
really reaches across the different disciplines.
Yeah.
So Well, Larry, thank you so much for being here today on Public Health on the Inside, and thank you to our listeners.
Thanks, Tom, for the chance to be here.
We'll see you again soon.
Bye-bye.